So the title of this is Heart Failure and the Mitral Valve. It's the chicken and the egg, and you'll see why. Next slide, please. So what I'm gonna try and do is just answer 5 questions. What is heart failure? What does the mitral valve do in the human heart? What are the mitral valve problems that can cause heart failure? And then can heart failure cause mitral valve problems? The answer obviously is yes, and that's why it's a chicken and an egg. And then what we can do about it, what the medicines are, what the surgeries are, and then is there anything beyond surgery? Next slide, please. Okay, so what is heart failure? So this is a heart. It sits in the chest, and blood comes into the heart through this big vein from the lower part of the body and this big vein from the upper part of the body. And it gets in this collecting chamber called the right atrium, and it goes to the right ventricle, and it gets pumped out of that blue artery to the lungs. And in the lungs, it picks up oxygen and it gets rid of carbon dioxide, and then it returns in the back of the heart through these veins to this collecting chamber called the left atrium. And from there, it goes through the mitral valve into this big pumping chamber called the left ventricle, and it gets pumped out of this red artery to the heart, to the body. So that's the circulation. It comes from the body to the heart, gets pumped out to the lungs, back to the heart, out to the body, back to the heart, like that. Okay? Well, you're with me so far? So heart failure is anything that makes it so the heart can't keep up with the demands of keeping the blood flowing forward. Next slide. There is right heart failure, where the blood can't keep up with the demand of the blood returning from the body to the heart. And that's where you get swelling in the body. And this is a picture of a man with swelling in his ankles and also fluid around his lungs. And this is an example of right heart failure, or maybe you can have right heart failure, you can have left heart failure, you can have both. This patient has either right heart failure or both left and right heart failure. Next slide. So what if the heart is capable of keeping up with the demands of the blood that's coming in from the body, but is not able to keep up with the demands of the blood that's returning to the heart from the lungs? And that's left heart failure. So this is a picture of, Rebecca, can you point to yeah, okay, so go to a little bit. That's, the right is an alveolus, an air sac, to the right of, there. That's an air sac. It's a microscopic sac in the lungs, and inside the air sac is the air that gets delivered from the bronchus. And the blue vessels is the blood that's getting pumped from the heart to the air sac, and the red vessels are after the blood is passed the air sac. It's now oxygenated and gotten rid of its carbon dioxide, and it returns to the heart. So if the heart can't keep up with the demand of that returning blood, it gets congested in those vessels to the left, and you get something called pulmonary edema, which is the picture below. Can you point to that? So now the air sac is partially filled with fluid, and those vessels that used to be bright red on the left are now not so bright red. You're not picking up as much oxygen because there's not as much room inside those air sacs. And that's called pulmonary edema, and that's a symptom of left heart failure. Now we've talked about right heart failure, we've talked about left heart failure. Next slide. So what does the mitral valve do in all this? The mitral valve is a one-way valve that separates the collecting chamber when the blood comes back from the lungs from the pumping chamber that generates a ton of pressure to propel the blood out to the body. Next slide. This is what it looks like. Rebecca, can you point to it? It's on, yep, it's this curtain on the right. Move your cursor about 2 inches to the right.
Oh, I'm sorry. Yeah, I thought you were going to follow the blood through the heart again. I'm sorry. That was what I was doing in my mind.
So just to orient you, those 4 red veins on the top is the blood returning to the left atrium. And then it passes through this mitral valve into this big, thick, muscular left ventricle. And when the heart squeezes, that valve closes, so the blood can't squirt back toward the lungs. And the pressure in that left ventricle now propels the blood out through the aortic valve, which is kind of hidden underneath that. It's that red valve in the center underneath the blue valve. Next slide. Next slide. Yep. This is just a pretty picture. Now we've got, have a look at me again. The first picture was the heart sliced longitudinally. Now we're gonna slice it across the top, and we're gonna look down into all four valves. And in the picture on the left, the heart is relaxing and receiving blood. On the left, through the mitral valve, it's receiving blood from the lungs. On the right, the tricuspid valve is receiving blood from the body, and it's filling the two chambers, the left ventricle and the right ventricle. Now the picture to the right, the ventricles have started to squeeze, and those valves have slammed shut. The mitral valve on the left, the tricuspid valve on the right, and the valves that let the blood out of the heart, the aortic valve and the pulmonic valve at the top, they're open. Okay? Next slide. So let's talk about problems with the mitral valve and how that can cause heart failure. I call that the chicken because mitral valve problems can cause heart failure. Go ahead. Now, let me just back up a second. There's about 19 participants here. There's probably about 20 reasons among you to have heart failure. Not all heart failure is the same, but we're talking about a specific subset of heart failure that involves the mitral valve. So this is a picture of the mitral valve with all the parts labeled, and the four images on the bottom are our classification of what causes that valve to leak. It's based on how the leaflets move. That's all for heart surgeons. There's not going to be a quiz on this. The bottom line is that every one of these problems on that bottom thing can be repaired, meaning we can make your broken valve restored and functional and durable, and that's always a lower risk thing to do than replace it with an artificial valve. And it also doesn't require anticoagulation like some artificial valves do. I guess I want to separate out one thing to talk about later. The lower right-hand image is a leaky mitral valve as a result of a heart attack. You can see the heart attack is at the very bottom of that picture, that whitish scar. And the problem there is that that heart attack has changed the geometry of the ventricle and caused the valve to leak. And that heart attack, what happens with scar in the heart is it can expand over time. It stretches under the pressure and can balloon out. And so we'll get back to that. Planting the seed, we'll get back to it later. Next slide. All right, so what happens when the mitral valve leaks? Rebecca, can you point to the left image? The LA is the left atrium. Blood passes through that mitral valve, which is that upside down V, into the left ventricle. And in this picture, the left ventricle is squeezing and propelling the blood out through the aortic valve. And the mitral valve is working. It's a one-way valve. In the middle, there's an acute leak of the mitral valve. And you see that heavy arrow in the center? That's the blood not only going forward where it's supposed to out through the aortic valve, it's also going backward through that mitral valve. And it makes the pressure in the left atrium high. And when the pressure in the left atrium is high, the heart has trouble draining the blood that's trying to come out of the lungs to get pumped around. Pressure backs up, and that causes the pulmonary edema that I showed in the earlier slides. Now in the picture on the right, so what we do for the picture in the middle is we treat that, and there are ways to treat it. If you have edema, pulmonary edema, leg edema, whatever, when there's swelling, we give diuretics. If fluid's the problem, let's see how we do with less fluid. So that's one of our types of treatments. Another one is when the mitral valve's leaking, the blood that's being squeezed by the left ventricle has to decide, is it going to go out the aortic valve or is it going to go backward through the mitral valve? Well, if the blood pressure in the body is very high, that's a high resistance to blood going forward, and it's relatively lower resistance to the blood leaking backward through the mitral valve into that low pressure chamber. So drugs that lower your blood pressure, particularly good is an ACE inhibitor, an afterload reducer, hydralazine, ARBs, a whole class of them. What I tell my mitral valve leaky patients is it's a little bit like a car, an old stick shift car with a slipping clutch, that if the clutch is slipping, you don't want to go up a steep hill, so you lower the incline of the hill and you can go forward. That's what reducing the blood pressure does. That's just talked about two big important arms of our treatment of mitral regurgitation. Now the picture on the right, suppose we had some mitral regurgitation and it wasn't severe enough to have heart surgery, and it was enough to be treated with medicines, which we've started, but it hasn't gone away completely. Over time, the heart starts to compensate for all this leaky blood. Some of the blood, as it's pumping, goes forward like it's supposed to. Some of it goes backward. So when it relaxes, not only does it have to pump the blood that just came from the lungs, it also has to pump the blood that just leaked backward into the atrium. So it enlarges. And you see the thick chamber on the bottom so you're pointing to the atrium, point to the ventricle. You see that ventricle is bigger on the right than it is in the center or on the left. Because the heart started to dilate and get larger so that it can pump more with each squeeze. Also, the blood leaking backward through the valve has subjected that left atrium, the upper chamber there, to higher pressure, and like a balloon with too much air in it, does the same thing. It gets bigger and bigger. Now, why is that important? Because if the atrium gets big enough, it can beat in a disorganized way, which we call atrial fibrillation. Now, why is that important? Well, those of you with atrial fibrillation know that it's unnerving. To have a rapid heartbeat, it can cause a stroke for reasons that I'm going to set aside to the question and answer period. But the main thing for the purpose of this talk is that the atrium gives a little bit of extra kick to the heart. It squeezes a split second before the ventricle beats, and it packs a little bit of extra blood into the ventricle so that when the ventricle empties, it empties as efficiently as it can. And in someone without heart failure, it adds about 10% of efficiency to each heartbeat. And someone with heart failure, it can add more like 30 or 40%. So if you have heart failure and you have atrial fibrillation, if we can fix that atrial fibrillation, either with drugs or with an electrophysiologist doing an ablation, your heart failure will get better. Next slide, please. Just for completeness, I'm going to talk about mitral stenosis. The other thing that can go wrong with the mitral valve is, besides leaking, is narrowing. It's something that we thought we got rid of in this country in the 50s when strep throat triggered rheumatic fever. But it's still very common in the rest of the world, everywhere but North America. In South America, in Asia, in Europe, in Africa, in China, there's still a lot of rheumatic fever. And then here in America, we have a particular problem that's probably a combination of wear and tear and abnormal calcium metabolism. It happens a lot in women with demineralized bone, that calcium finds its way to the ring that the mitral valve attaches to and onto the leaflets of the mitral valve, and occasionally we can get mitral stenosis without rheumatic fever. But the problem here is that the orifice of the valve gets narrow and blood is blocked from traveling into the ventricle, and that can cause left-sided heart failure. Next slide, please. So the two problems I spoke about so far, when they get severe, we fix them with surgery. We don't fix them if they're mild or moderate to severe. Moderate to severe is a thing. It's not, it's a quantitative thing that's halfway between moderate and severe. We don't operate on moderate to severe. We only operate on severe. So if you get back an echo report that says moderate to severe, don't get scared that you're going to have a heart operation. It is not the case. Now we're going to talk about, can heart failure cause the mitral valve problems? This is the egg, part of the chicken and the egg. So next slide. So Rebecca, can you point to the picture in the middle? This is a normal normal ventricle with a normal heart and normal mitral valve. Can you just point again to the mitral valve, show people where it is? It's that little, those two, the upside down V with the gap. Yep, exactly right. And then the picture on the left is there to remind people that the mitral valve, those leaflets are suspended by little muscles called papillary muscles. Thank you. And they are together. They're fairly close to each other. They're about 1 centimeter apart. So what happens if the heart dilates and from a cardiomyopathy and it loses its pyramid shape and it becomes more spherical? That's the picture on the right. Those papillary muscles start to move apart. If you can look at me again for a second. Here's what a normal mitral valve opens and closes looking like. When the papillary muscles move apart, they get pulled down, and then the ring that the mitral valve attaches to starts to pull apart. So now the leaflets are not moving as much as they should, and they're not meeting in the middle anymore, and there can be a leak of the mitral valve that's with normal mitral valve leaflets. It leaks because the ring has gotten too big and because the papillary muscles have pulled it down, restricted it in the wrong direction. Turns out that we can fix that too with surgery. We can do a mitral repair or we can do a mitral replacement, and it works, and it makes patients' symptoms go away, and we can do it safely, and we can get people through the operation. But long-term studies have shown that it does not make people live longer. And surgeons prefer not to operate if we're not going to make you live longer. Next slide, please. Okay, so what can we do about a leaky mitral valve? Unlike the aortic valve, which when it leaks severely or is narrowed severely, there's no amount of medicine that's going to fix that. The mitral valve's a more complicated valve, and sometimes there are therapies short of operating. Next slide. So the medical therapy, we talked about lowering the blood pressure. That's the afterload reducers. We talked about the diuretics. We talked about treating the atrial fibrillation. That leaves cardiac resynchronization therapy. All right, can you look at me again? So the heart has a conduction system like I showed in the very first slide, and it conducts the impulse down to the apex, tip of the heart, and then it squeezes and kind of wrings the blood up toward the base. So it's supposed to squeeze it this way. Sometimes people have, with heart failure or with conduction problems, one part of the heart doesn't beat in a coordinated way. The impulse doesn't travel simultaneously to both walls, and they beat like they're supposed to. And one wall beats a little before the other. So can you see my hand? So it's not efficient. They're kind of waving at each other. And that we can tell with an EKG and an echo. And that responds extremely well, surprisingly well, shockingly well, to something called cardiac resynchronization therapy, which is a fancy pacemaker that doesn't only pace the right ventricle, but it also paces the left ventricle opposite to the right ventricle at the same time and re-coordinates the heart. Electrophysiologist does that. Next slide, please. So we've done all those things, and the mitral valve leak has not gone away. In fact, it's still severe. We can operate, and we prefer to operate when the primary problem is the valve, like we discussed. We only operate on severe regurgitation, despite all the other things that we tried first. We can, for the most part, repair all leaky mitral valves. The one carve out is the one that I talked about way at the beginning, the scar in the heart, where we can repair that valve and make it perfect, but 3 or 4 or 5 years later, as the infarct scar starts to stretch more, the valve can leak 4 or 5 years later, and that is not a good outcome for us. So that's one situation where we say to ourselves, we can fix this in the operating room, but it's not going to last for the whole life, and so we will replace that valve, even though it's technically repairable. It's not durably repairable. So anytime the mitral valve's a problem, that's when we operate. And for we can repair some stenotic valves too, but 60% of the time we can't repair it. and have to replace a stenotic valve. Next slide, please. Here at Chester County, we like to do all of our mitral valve surgery minimally invasively whenever we can. If we don't have to do something else like a aortic valve replacement or a coronary bypass, we do it through a little tiny incision on the right. We connect it to the heart-lung machine with the femoral vessels at the top of the leg. Maybe you could point to that. And then we make the incision in the center of that white tissue retractor. And we can see as well as we have to. We have these long instruments that look like chopsticks with little tiny scissors and forceps on the end. And it's a particularly gratifying operation for me. I enjoy doing that operation. Next slide, please. Okay, so what if surgery is not appropriate for severely leaking mitral valve? And the whole category is this secondary mitral regurgitation, the mitral regurgitation that really is not a mitral valve problem, it's a ventricular muscle problem. Or if you got a surgical mitral valve that is just too risky to repair, because besides your heart, you've also got a lot of other things that make your surgical risk too high. And we've tried all the other things, and we don't want to go to a heart transplant, and we don't want to go to a mechanical support with an LVAD. There is a new therapy called a mitral clip. Next slide, please. So I say it's a new non-surgical procedure. It's really not. It was invented almost 20 years ago, but it took until now to get it through the FDA and to get it out for testing and to figure out who to use it in and to use it in enough people that we've been following it for enough years that we can offer it here at Chester County and in the regular population, that you don't have to be part of an academic study anymore. And that was a result of 2 giant studies that came out in 2018. And here's where I'm really hoping the math professor will give me a second before he gets mad. The 2 studies both came out almost the same time in 2018. The first was this European MITRA-FR study, which had 307 patients, and 92% of the time they were successful at reducing the mitral regurgitation with a single clip. I'm going to leave the technical details to my very capable colleague, Dr. Raza, who's going to speak next. And maybe he'll talk about the study too. But unfortunately for the Europeans, when they studied those patients for years, they didn't show any benefit over just giving the patient pills on either survival or on readmission to the hospital. And that was disappointing until the American study came out called the COAP trial. And that one had about twice as many patients, and they had a better procedural success because the Americans were more likely to put 2 clips in if 1 clip wasn't enough. And it showed a definite benefit over just pills alone on both survival and on readmission to the hospital. So why is there a difference? The COAP trial was more careful. They excluded people that were too late, people that really should have a heart transplant instead. They figured, well, let's try this. What do we have to lose? But if you include them in a trial, it dilutes the good results with ones that aren't going to get better no matter what you do. The COAP trial also excluded the too soon patients, the ones that didn't have failure of medical therapy. And what that means is, if we're going to give you medical therapy and you're going to get better, if we also put a clip in you and you didn't really need it, you would have done just as well without the clip. That also dilutes the successful group because those were patients that that would have done just as well without the clip. And finally, the American study developed this concept they call proportionality, where they looked at how bad the mitral valve leaked. It's a little bit like what surgeons do. We say, this mitral valve is not bad enough to explain all your symptoms, and we don't operate on those. They didn't clip those either. They only clipped the most severe patients. So I think the American study was a little better executed, and it showed there are some people that if you get them soon enough, as soon as medical therapy is failing and not too late when the ventricle's too far gone, we can help a lot of people. And this is going to replace surgery as our first choice for functional mitral regurgitation. Next slide, please. So this is my summary slide. And I got three things I hope you'll remember. One is that if you have heart failure, look for mitral valve problems. And the way to look is with an echocardiogram. And you may have had heart failure for years and years with no mitral problem, and it may develop in you. It's good to detect that. It's good to know that, because opens up a whole new avenue of treatment. Second message is, it doesn't matter to us whether it's a chicken, meaning a mitral valve problem that's causing heart failure, or an egg, meaning a heart failure problem that's causing mitral valve problems. We have solutions to both. And finally, I hope it becomes evident that with all these advances in heart failure treatment and all these other heart failure related areas like atrial fibrillation treatment, that you need a whole team. You need a cardiac surgeon, you need an electrophysiologist, you need a heart failure specialist, and you need somebody like my colleague, Dr. Raza, who's going to tell you about structural heart approaches to this problem.